any questions, if you could just place those in the chat and they'll be answered during the session or at the end. If time runs out, we've got quite a few people joining us tonight. They certainly will be followed up after tonight. There's resources and slides that will be emailed after tonight's presentation, and that includes the referral form. There's an evaluation at the end. If you don't mind completing that, we'd be very, very grateful. And thank you everyone for attending tonight. And we have James Brown presenting for us. James is a gynecologist and clinical co-lead at the Southwest Specialist Menopause Service, providing clinical support to GP specialists through Australia's first 100% virtual menopause hub. He also provides menopause and general gynecology services through the WHRIA in the Sydney CBD. He's currently completing his PhD in health economics through the University of Technology in Sydney. We also have Susan Simpson online with us. Susan is the Western New South Wales LHD Menopause Coordinator and Senior Physiotherapist, and she's based in Orange. James, if you would like to start sharing and you can take over. Thank you very much for being here tonight.
All right, cool. G'day, everyone. My name's James. Thanks for being willing to come along. I'm a gynecologist, as you know, working in the Menopause Hub, of which your district is a referral site. So please send any business you've got our way. But the purpose of tonight is not to tell you what you already know, because I know that you've all got a lot of experience dealing with menopause, but just giving some practical advice on sort of the approach that we take that we've found simple, but also just to kind of reach out and say that we're a helpful resource when things get curly, and feel free to reach out. Our job in the hub is not to sit in the ivory tower of the hospital and do that type of medicine. It's actually really to support people in the community and clinicians like yourself who are on the front line and are increasingly being asked to do more and more complex menopause care as people get more interested in this stuff. So it's meant to be practical, is the plan. Feel free to write questions, all that sort of stuff, and we'll go through it as we go along. No conflicts of interest. Beautiful. All right. So you guys already know this, but I have to put it at the beginning. I'm sorry. So menopause is basically when the ovaries run out of eggs. And because eggs really were the primary source of estrogen throughout the menstrual cycle, once the eggs go down, the amount of estrogen that it's available dramatically goes down too. So we call menopause traditionally a year after that last period, but really the transition can take up to 5 years on either side of that. And people can really be suffering with a lot of estrogen deficiency whilst their eggs are running out or whilst their periods are starting to space out. So you don't have to wait until it's completely finished in order to make people eligible for treatment. So why does it matter? It's an inevitable process. And it has a huge impact on people's quality of life. So symptoms can affect over 80% of women, with 40% of them being moderate and severe. And despite this, only a minority of women still seek treatment. And in some countries, it's down to, say, 1 to 2% of eligible women are accessing treatment for what can be a pretty disruptive condition. The other big question is, why does it happen now? Like, why does it matter now? So there seems to be this groundswell of interest in menopause, particularly in Australia and New South Wales. And part of that in the state is the development of these menopause hubs that you might be familiar with, which I'm fortunate enough to work at. But there's also one in Eastern Sydney, North Sydney, and then one in John Hunter, each divvying up a quarter of the state to be able to provide, referral services to assist GPs in the community. More broadly to this, and you know this better than I do, there's increased MBS incentives to doing menopause assessments and generally just doing women's health interventions. And what that really means is that a lot of women's health that was once seen to be maybe gynecology type stuff is actually being relied upon, particularly in regional settings, by the primary care workforce, which again, you don't need me to tell you. What I suppose seems suspicious is, like, why does everyone care now if it's been a problem for so long? And this is a graph I found that I think is pretty interesting coming out of the statistics coming out of Canberra. What I want to draw your attention to, so basically what this is the percentage of women still employed as their age increases on average. And so as you can see, the difference between the orange and the red line, I want to draw your attention to the shift that happens around the age of 50 to 60. What you'll see is that over the last 20 years, there have basically been a frame shift that the same amount of women are in the workforce at the age of 60 now as there were in the age of 50. And this is really the people who are impacted by menopause. And so their productivity, their engagement in the workforce is important, but more broadly, there are large political force that we want to support as a government so that we can get those votes. So I think there's obviously the patient advocacy part of things, but there's also that this is an important demographic to support now for the government after being ignored for so long. That's the cynical part of me, at least. So again, you don't need me to tell you how to suck eggs. You know how to do this. But because GPs are really taking the great shoulder of looking after menopause care, and the point of these hubs is not to absorb all of that responsibility and to just take away and act like we know everything, but rather actually to be a support service for that increase in frontline activity. So hopefully this presentation, you may already know some of it, but it's just sort of a quick start guide to help you initiating treatment and tips and tricks for women who may be seeking MHT or HRT, which is interchangeable. Cool. So all you need to know, so people come in and they ask like, oh, can I get some HRT, MHT? And it makes it sound like it's this specific category of medications. But realistically, all it is estrogen supplementation with a progestin just to protect the uterus. Technically speaking, Zoli, the contraceptive pill that I'm sure you've prescribed, that is technically HRT. It has estrogen in it and it has a progestin. It just happens to suppress your cycle at the time. So when people sort of start talking about this category, it tends to get kind of expanded and inflated in their mind, when in reality, all it is you've got an estrogen deficiency and we're supplementing that with estrogen to a level that was previously physiological. Nothing too exotic going on. And if you can anchor it in that physiology, it makes decisions much easier. Important to mention, I had a lady actually question me today about this. The purpose of the progestin, and we use progestin because there's different types of progestogens that we use for this purpose. Their purpose exclusively in HRT is to counteract the thickening of the uterus that unopposed estrogen would do. And if a progestin's not given, that thickening can lead to endometrial hyperplasia and very rarely precancerous conditions after a really long time of neglect. Does it have direct effects on cognition and things like that? I'm not sure if that's fully borne out, but that's starting to be discussed in social media, so you might get those questions. Cool. So people come in and I suppose the expectations are becoming increasingly high for MHT about what does it do. My approach is always just to anchor it in the specifics of what the cycle was doing before and what's happening now. So really what it's doing is that the symptoms caused by menopause are typically just the body saying, I'm not getting enough estrogen. And once you meet that level of satiety for those receptors, then they'll stop whinging about it. Giving more estrogen on top of that won't make them whinge any less because the whinging has stopped. So you're just meeting a minimum standard of estrogen that the body needs to function. Now, each woman has a slightly different set point where the receptor is satisfied. And below that point, the body doesn't function correctly. But going above that point doesn't have additional symptomatic benefits. Not to get too in the weeds about this, but this kind of minimum estrogen set point tends to change over time as people age. So when someone goes through menopause at the age of 31, their needs of estrogen at a gross level, at a quantitative level, is probably higher than someone at the age of 51 or 52. I like this theory because it also helps to explain why people's symptoms go away as they get older, which typically is just the pattern of those receptors having lower and lower expectations. There's a small group of people whose expectations never decrease, but most of people will eventually become asymptomatic about 5 years after menopause. And the other important thing to remember is that this level of satiety is anchored in the physiology of the menstrual cycle. So when someone is just about to have their period, that's where the estrogen's at its lowest, and it would very rarely dip below, say, 150 to 200. So if we can chip people's HRT or MHT up to that level, not that we use levels, but just as a theory, then those symptoms should go away. There's no noble reason that making someone's level 600 makes any sense from a physiological level, because it'd only be about 3 or 4 days of the cycle when it would be that. But that's the mechanism behind what we're trying to do. Meet the set point that the symptoms are telling us is unsatisfied. Cool. Perfect. So just a brief history. I know that everyone talks about this study all the time, but this is what basically effed everything up, which is the Women's Health Initiative study back in 2002. And so the point of that study, just in case patients ask about it and you haven't run into it, is that they tried to give combined hormone replacement therapy for long-term health benefits in postmenopausal women. The important thing to remember is that this was not given to symptomatic women. It was given for preventative health reasons, explicitly cardiovascular disease. Unfortunately, it had an outsized prevalence of cardiovascular disease and stroke and then breast cancer, which then led to this big scare that was widely publicized and led to a rapid drop in prescribing of MHT for a very long time, which we're only coming out of now. And so it's taken a long time of us to reanalyze this data over and over and over again to kind of restore public confidence. I want to show you, oh yeah, so I split this around. Cool. So this is to show you the change in MHT prescribing the moment that study was published. So as you can see, 2001, 2002, a rapid drop-off in MHT that's only starting to be upticked again in the kind of most recent years. There was an interesting study that came out of the US that stratified this pattern by ethnicity. And it was really awful to see that, for example, for African American women, HRT prescriptions remain at 0% still to this day. So yeah, it did a lot of damage and we're coming out of that now. A lot of people did not get treatment and you're now fighting against a lot of these old beliefs. So the difference now, though, is not that we know more as much as there's a whole bunch of other MHT types and modalities and knowledge that we didn't know before. And so we can give people more options with more information and we can sort of help them make the decision without them getting too spooked about the risks because we'll be able to explain them quite neatly. Initial assessment. Now, I don't need to tell you how to do this, you're experts, but some specifics just to consider is what their menstrual pattern is doing. So you really want to define if they're perimenopausal or postmenopausal. There's also, if you want to get in the weeds, there's early and late perimenopause, which is typically defined by a difference in patterns. So your early perimenopause for physiological reasons will be more intense, so more frequent, more heavy, more painful periods with a lot more PMS. And then as you get closer to the final period, those periods will start to space out. And those months without an ovulation will be months with estrogen deficiency, where you'll suffer fairly traditional menopause symptoms. Contraception history is helpful, obviously, but it's particularly helpful for finding adverse reactions to the pill in the past or the Mirena in the past, which will help give you a sense of which progestin to give a lady and which ones she's unlikely to react to well. Surgical history is obvious because they still have a uterus or not, which is important for how we treat, and obviously do all your screening. But the most important things to ask, obviously, is symptom distribution and previous treatments. So symptoms distribution helps you decide whether you need to take an upstream approach, so treat the hormone deficiency so the downstream sorts itself out, or if there's one singular isolated symptom of trouble, let's say vaginal dryness or hot flushes, you have the option then to just deal with that locally without going nuclear from day one. And obviously previous treatments prevents you from looking like the silly goose if you give it the same thing again. Contraindications. Surprisingly, after all that scare in the early 2000s, there's not that many. It's unexplained PV bleeding. And when we say unexplained, it's not irregular periods, things that you think is reasonable and physiological as a pattern, that's fine. But like profuse ongoing bleeding that hasn't been fully diagnosed or worked up, obviously sort that out. Acute or severe liver disease, current VTE or stroke, and then hormone-sensitive cancers. There's a relative consideration around cardiovascular disease and cardiovascular risk factors, which is a talk in and of itself. It's a bit of a minefield, but just remember it's a consideration, not an absolute contraindication. If you're super interested in cardiovascular disease and MHT, the British Menopause Society just released a lovely little guideline where they're absolutely gung-ho about MHT, where they said that if you're on transdermal MHT, and you have a heart attack, you do not need to stop it. So there we've got some increased confidence in this area, but it's quite nuanced. Investigations. So some people may choose to do hormones to help for differentiation. It's not necessarily necessary, and it's often hard to interpret. Most important thing is try not to use those measures to dismiss people's symptoms, particularly in perimenopause. If someone is having widely irregular periods, or even just frequent ones, there is no way for you to capture the snapshot of their menopausal pattern in order to lock in the diagnosis. You can treat them on face value and see how you go. There's the Monash toolkit around menopause that recommends doing just a general midlife panel, which general practitioners do all the time. Again, I don't need to explain that. And then you can also consider your typical oligo or amenorrhea panel if you have doubts about why their periods are becoming less regular. So things like prolactin, etc. If they have a formal onset of complete menopause before the age of 40, That would constitute primary ovarian insufficiency, and some people would recommend doing karyotyping, Fragile X, pre-mutation testing, and an AMH. But the AMH is super controversial, so it's not mandatory. Um, Someone in the chat has asked whether or not a GP can refer to AMH. They can, so you absolutely can refer for an AMH, but it's not covered by Medicare under any circumstance. So the last I checked, it was about $90, but with inflation, it may have gotten further. So yes, it's an out-of-pocket cost, but the biggest punishment is you having to explain the results, which I found gnarly in the past. Cool. So we want to initiate MHC. So someone comes in, and we'll talk about sort of patterns of profiles of symptoms later on in the talk. Let's say someone comes in and they have menopause symptoms. What's the first thing you do? What you do every day, just general lifestyle advice. We recently got a talk by a dermatologist about the skin and hair changes of menopause, and I was hoping to hear all these fancy new treatments for all of these things. And again, the best treatment is just general lifestyle advice about, exercise, eating right, not drinking too much and not smoking. It's all pretty simple. It was simple. What it's important to remember, though, particularly around weight and exercise, is that in the perimenopause, the metabolism is completely sabotaged by the change in hormones. And so it's really, really hard to maintain weight. And so it can be extremely demotivating if someone's doing everything in their power and yet their weight is increasing and particularly redistributing around the tummy. And so it's important to acknowledge that it's really not a fair fight and that doing anything is better than nothing, but measuring the scales and trying to keep up a pace that you'd expect 10 years ago is a recipe for sending people loopy. So a little bit of compassion in that regard, it seems pretty awful. So then where we're getting to the nitty-gritty of the talk really is we want to initiate this. So what type of MHT do we want to start with? So if someone is postmenopausal or in the late perimenopausal phase, now there's no specific guidelines, but I would argue, say, a period every 3 months, then you would consider systemic MHT. If they've just got local genitourinary symptoms of menopause, so the dryness, the urinary urgency, that type of thing, you may be able to get away with local MHT, which I'll talk about shortly. And then the other trick for young players, but if I teach you too much, you'll put me out of business, but in early to mid perimenopause, where the periods are more intense and there's a lot more PMS, then it's really important to not just give additional hormones, because there's a complete surfeit of those. It's also to include cycle suppression through a form of contraception as well. And we're going to go through these in a bit more detail as we go along. But if you can categorize your woman into one of those categories, it will give you a starting point for what she probably needs. And this is kind of how I think things through when I hear the story as well. And if they say, look, I'm getting a period every 21 days, but I still get hot flashes and I've got this moodiness and this PMS, it's a classic cycle suppress first and then add back estrogen as you need, versus the woman who's having a period every 3 months and says, I feel kind of okay in that month, but the other months I feel rubbish. You can probably get away with just doing traditional HRT, even though she's theoretically still cycling. But they're the 3 big categories I would use. Once you've worked out your category of what type of medication you're going to give, the next thing you're going to think about is whether or not you have to give estrogen or progesterone. So if they have no uterus, you just give estrogen only, remembering that progestin is only there to protect the uterus from the estrogen. So no uterus, no progesterone, no problems. If they have a uterus, you're going to have to give estrogen and a progestin. But if they have no uterus, which I had a lady today just like this, who has no uterus but a history of endometriosis, the formal guidance is to give estrogen and progestin. The rationale behind that is that the ectopic endometrial tissue that's still potentially on the peritoneal surface can react to the unmitigated estrogen and either recur in symptoms or in very extreme circumstances transform into a form of cancer. Now, I have to be honest with you, I'm a bit of a skeptic of that, because let's say we have a lady put on Slinda, so she's not getting any estrogen, but her baseline estrogen might be 200 just because it's suppressed and she's not cycling. It's not going to cause worsening of the endometriosis, that little bit of estrogen she's getting all the time. And that's no different a hormone profile than someone on low dose HRT. I'm giving you the formal advice, but I personally think that if they've got no uterus, it's not absolutely mandatory, but you wouldn't be doing the wrong thing. And there's really very few downsides other than the breast cancer risk, which we'll talk about in a little bit. But yeah, so you've worked out your category. You then worked out if they've got a uterus, so you know which ingredients to give, and then you work your way down. The next big question you have to ask yourself is that if you're giving estrogen and progesterone, what type of progesterone do you give, or what type of progestin do you give? Do I actually go through those options? Anyway, we'll go through it. So the two big categories is cycling women versus non-cycling women, or minimally cycling women, like I mentioned before. So if someone has regular cycles and you want to give them HRT, the official lesson is to give them cyclical progesterone, which is, double dose of prometrium in theory for 12 to 14 days out of the cycle based on the calendar. Versus if someone has a very minimal cycle or not much at all, or none at all, then you just give a little bit of prometrium every day. My argument would be that if someone is having regular cycles, then realistically giving just estrogen on top of that and a cyclical progesterone will really mess with their cycle a lot, because the withdrawal of that cyclical progesterone may cause a secondary bleed. So my little habit is to just do continuous for perimenopause, like late perimenopause and postmenopause. And if they're really regularly cycling, have a decent think about giving something that's also going to suppress and control the cycle, something like Slinda or a Mirena, which someone's already brought up in the chat. Okay. Perimenopause has a lot of benefits from suppressing the cycle. Most directly is controlling luteal phase, so the 10 to 7 days before the period where the PMS can be really bad. And I also have a little bit of a theory, this is not scientific whatsoever, but if someone's still having wild rises in hormones and they go from very low to very high to very low to very high, that expectation set point never really gets diminished because it keeps on getting a little dose throughout. And so suppressing the cycle and then putting a little bit on top calms everything down and buffers it without you having to try and work your way around those different loops. But that's sort of technicalities. But ultimately, you make a decision around cyclical or continuous, or in theory, Mirena would be another choice. Cool. Initiating it. So in terms of starting it, so we've decided on route, we've decided on whether or not we need progesterone. Now there's how we're going to give this estrogen. Okay. There are three broad categories, and that is oral, which is daily, patches, which is twice weekly, and gel, which is estrogen only and daily. So with oral, there are both estrogen only preparations as well as combined preparations. I don't work for any pharmaceutical company, but that would be something like Femiston, Clyogest, Bijuva. They all have their pros and cons. Patches, there is a combined patch called Astalis, which you may have heard of myth because it's basically unable to be found these days. It has an estrogen component that's fixed, but it has two progestin variations. So one is a moderate dose and one is a higher dose. You would give the higher dose if they had breakthrough bleeding. But more commonly now, people are on the estrogen only patch and electing to use a progestin such as prometrium on the side or a Mirena. But what everyone seems to be getting flogged on these days, and I'm just as guilty as everyone else, is starting people on gel. So where oral is 1 tablet a day, patches is 1 patch twice weekly, the gel is it's at least about 2 pumps per day of gel that can go up to 4 pumps feasibly. Okay. So, and what would it look like is you do your daily sort of pump of gel, which is 1 smear down one arm, smear down the other arm. If you're onto 3 or 4 pumps, you get to start using the legs and you don't really rub it in. So that type of gel in particular if you're using estrogel in particular, doesn't like being rubbed in. It actually absorbs through evaporation. That's the rationale for this whole whole of arm thing. And so how we ask people to do it is you take a really big pump. I heard a really cool idea the other day that a patient showed me where you get the cap of the estrogel container and you squeeze the whole thing onto the top of the cap of the container, the lid, and then you kind of use it like a chapstick across your arm. Hell, it worked for her, but I said I'd pass it on to other people who might find that interesting too. And then you let it dry for about 5 to 10 minutes. Usually this is done before bed. There's no real risk if the dog licks it or you cuddle up next to someone next to you. It'll all be absorbed within 5 to 10 minutes. The benefits of each of these I think we'll talk about, but broadly speaking, oral has very easy absorption. So it's very predictable, the effect of oral. whereas patches and gel have an extremely variable absorption rate. And I'm sure you guys have seen it in your clinical practice where there's some people on ever increasing doses of gel and they don't seem to get any better. And you may consider doing a blood test and it's just not touching the sides. There was a little study coming out of like England a few months back that showed that they had some ladies on like 8 pumps of gel somehow, and they still didn't break like a estrogen level of about 150. So that was about 1 in 5. So it's not unreasonable. But generally speaking, 2 pumps of gel and a prometrium is like a safe start for virtually every person that needs MHT, but we'll talk about the nuance shortly. The reason why everyone goes on the gel or the patch is because transdermal estrogen is the only form that has no VTE risk compared to oral. I think we'll talk about this with risks when we come up to it, because we're going to be talking about risk counseling. But that's why we kind of land on transdermal for estrogen. My argument for why we all start on estrogel is actually because it's a really easy way to commence and titrate and dose find for someone. So if someone goes, oh, it's not enough, you chuck them on 3rd pump and they don't have to buy a whole nother box of patches. So it's a really practical, easy way to dose find. And there are ways of then transferring over to a longer term option once you find that dosing regime. That's how I do things. And patches are really, as you already know, in and out of stock. Dosing. So you've decided you want to give it. Where do you start? I start everyone on bog standard medium dose, bar none. It's really hard to predict how much people need. But physiologically, medium dosing will get most people to a physiological level of about 200 pretty easily. That would be between 1 to 2 milligrams of oral. It'd be equivalent of a 50 microgram patch, or it'd be 2 pumps of gel, or 1 milligram of the Sandrina gel. They would be all equivalent for a medium starting dose. I try not, unless there's some extreme circumstances, to start gently. I think just fiddling around too much at the beginning is a bad choice. Just do everything with the same person so you know what to do from there and you can kind of compare them to previous experiences. That's my approach. I keep things simple because I'm pretty simple. The Prometrium, or I shouldn't use the brand name, but we use Prometrium, which is a body identical, which you'll start to hate the term of, which is just progesterone the same as your body produces, is 100 milligrams a day if it's continuous, but 200 milligrams if cyclical. Some people choose to take 200 milligrams continuous either for bleeding control or for sleeping help. And that's no danger to them whatsoever. It just slightly increases the risk they can't tolerate it, but it's pretty well tolerated, to be honest with you. So don't be afraid to keep someone on 200 continuous if you think they really need it, but just don't do it if it's not necessary. So if you've decided, if I had my like garden variety postmenopausal, someone with hot flushes and a bit of brain fog and joint pain comes in and they've got not many risk factors, they usually exit with 2 pumps of estrogel, typically, because I know they can get that supply, walk down the street, trip over it, it's there, and it will come in packed with 100 milligrams of Prometrium. All right, really standard, really easy to kick off. So someone in the chat's asked, with cyclical 200 milligram from which day to which day? I must confess that I'm not a huge fan of cyclical, but the official wording is that you should do it on calendar day so that people can remember which day it is. Because if you start doing like day 1 to 12 of your cycle, it's really hard to gauge. So you do the 200 milligrams for 12 to 14 days from the start of the month, each month, which may eventually sequence with the cycle or may never. And that's why I kind of don't love it. Cool. Moving on. And again, no worries if there's other little questions that come up as we're talking, but there will be time at the end too. We're making okay time. Counseling. So this is actually the hardest part, right? So the medicine I just described is super straightforward, but it's actually trying to explain to people what they're getting into and what the risks are so they feel comfortable about it. We're in a weird environment now where there's some people who are really underinformed, and then there is a whole group of people who are now overinformed, not through any, nefarious choice of their own, but because they're being bombarded with social media content, and we know that the algorithm prioritizes menopause stuff for some reason. It must be the demographic. For me, because people are suffering with a lot of noise, it's important just to be really simple, give them the key messages, make them feel confident about the choice they're making, and then offer that support as they move along. What I'm about to describe is literally the words that I use. And then if you're the type of person that likes to give people written information, then they can get information from Jean Hales or the Australasian Menopause Society. Cool. So first thing, you may have heard of a thing called the window. So there was a theory coming out of the WHI study that if MHT was commenced within 10 years of the last period and under the age of 60, then that is maximal safety, particularly from a cardiovascular risk perspective. Truthfully, this was only based on one study in asymptomatic women. When I first wrote this talk, I said I felt there was flexibility. There is now data showing that commencing it in theory up to the age of 65 is not going to make people spontaneously combust and have a heart attack. But that when people talk about that, you can be very confident starting MHT within that window described above, but acknowledge that, look, 60 and 3 months is not a complete contraindication to starting MHT, particularly if they only went through menopause 5 years earlier. But that's where that theory comes from. That's how I explain it to people. Second thing I mentioned is that there's actually short-term risks of this. So when people have been postmenopausal properly for an extended period of time, when you reintroduce estrogen, there will be an estrogen over-response by the body, basically licking its lips that all of a sudden estrogen's back. So you'll get a lot of mid-ovulatory symptoms. That would be things like breast tenderness, cramping, spotting, bloating, and mood disturbance. It can be really disorienting. And it can also be really disappointing because people have read online that this is the fountain of youth, and all of a sudden they feel weird for a month. The good news is that most of that goes away after 1 month. So if they can just chip away and get over that hump, most people are fine. A lot of people who've proclaimed to have side effects to MHT never got through that first month, and that's no through fault of their own, but most of that would have gotten better by the time that first month's finished. And I used to not tell people about this, and then I got tons of emails and phone calls. So now this is part of standard counseling every time I start MHT. So the question here for cyclical progesterone, how long do you advise to continue a cyclical before continuing dose at bedtime? So all progesterone I should have mentioned this. Thank you for bringing that up. All progesterone should be given at nighttime because it has a sedative effect and helps people sleep. When it comes to cyclical versus continuous, the woman tells you when that happens, and that's when her periods start to space out. I'd give continuous to a lot of people, but it's a pretty safe bet that if someone has periods less than every 3 months, then continuous is the right choice for them. The risk of doing continuous too soon is that they might just get some breakthrough spotting, but I haven't seen a whole lot of that. But that's some guidance I would give. So cyclical versus continuous is based on what the cycle's doing. That's the short term. Great. All right, long term. So again, I'm a simple guy, right? So there's only 3 long-term risks of HRT. We'll talk about them. So it's going to be VTE, cardiovascular risk, and breast cancer risk. And I usually say them in that order because it's easy to explain them in that order. So first one, there is indeed an increased risk of VTE and stroke if given oral estrogen. This technically works as a multiplier effect based on someone's background risk, much like the contraceptive pill, but with a lot less potency. So as people get older, their absolute risk of VTE goes up. And so therefore, this multiplier effect kind of increases as a square root, right? And so I think I was watching something the other day. So let's say your background risk is, say, 4 in 1,000 at the age of, say, 60 or 70. You taking oral HRT could turn that into, say, 16 to 20 per 1,000 when it starts to become a real number. Cool. And so to mitigate that, we give transdermal estrogen. So transdermal estradiol has not been shown to increase clotting risk whatsoever. There's some theory about dosage, but anyway, broadly speaking, we have not been able to show consistent increases in clotting risk with transdermal estradiol, whether it's a patch or a gel, whichever gel it is, doesn't matter at all. Now, why is this the case? It's because when you take oral estrogen, it gets metabolized by the liver. In having done, in the metabolism process, it spits out clotting factors through that, and then that leads to the increased procoagulation. That's the theory, at least. By taking something transdermally, you completely bypass hepatic metabolism, so you're just getting the good stuff straight into the system. And there's no way that the clotting factors will up-titrate as a result of that. Cool. That's VTE. So if you give someone transdermal, I can confidently say to them, no matter what your age is, your clotting risk will not go up. Second thing, heart disease. This is a really complex area, but this is what I tell people. We used to think that HRT was a risk for cardiovascular disease, when in reality, what we're starting to learn is that if you take MHT up to the age of 60, it is a net improvement in your heart disease risk. What often gets buried in all the WHI talk is that even in that nasty study where people got really sick, there was still a very significant improvement in lifespan in the group that got HRT. And so there is some good stuff happening. So what I say to someone is that if you take your HRT up to the age of 60, the risk of heart disease is not a risk, it's a benefit. After the age of 60 to 70, we're not sure. It's probably neutral. After the age of 70, we just don't know for someone who's been continuing it. In theory, this risk is further mitigated if you started it and continued it from that acceptable window, but this is becoming more flexible. What makes this counselling about heart disease quite complicated is that if you've got pre-existing heart disease, and we've got evidence that shows that MHT makes your heart disease risk better, wouldn't a cardiovascular risk factor in the right population actually be a reason to give it, not to avoid it? But that's a whole other controversial talk to have another time. And the third category is breast cancer. So we've spoken about VTE, heart disease, now breast cancer. So this is where I go, yes, there's no clotting risk. No, there's not really any heart disease risk, but you're right, there is indeed breast cancer risk, but it is only present if you give someone combined HRT. There is actually a net decrease in breast cancer prevalence in people taking estrogen only. Not that that's a reason to take estrogen. We're not sure why this is the case, but this is the truth. Combined HRT, increased breast cancer risk. Estrogen only, decreased breast cancer risk, or the same. Now, how I counsel this is giving absolute numbers. So just being a woman on planet Earth, your risk of breast cancer is 1 in 7 over a lifetime. And if you take MHT, at worst, you get 1 extra case per 1,000 years of use. This is detected cancers, not deaths from cancers. That 1 in 1,000 is derived from that WHI study. So it's a roundup of a medication we don't give anymore. So the breast cancer risk is dramatically lower than that, but that's at worst what it is. And proportionally to 1 in 7 just living on planet Earth, it's actually not too bad. But indeed, it is an avoidable increase. Cool. People will ask about the long-term benefits. It's important to mention these, but they are not really a justification for giving it in independence, but it's up to you. Bone health, so it increases, prevents osteoporosis. We spoke about heart disease. We're not sure if it helps dementia. It definitely decreases all-cause mortality, but important to remember this is not the fountain of youth, and you should give it just for that reason. But a lot of people will ask you, and it's your choice to decide. Cool, perfect. So follow-up. So you've started someone on the MHT. When do you follow them up? I generally pick the magic 3 months because it gives you a time for that 1 month to pass, and it gives a further 2 months for the symptoms to get sustainably better. At that appointment, you gauge whether their symptoms have been improved, and you identify any stuck symptoms, such as vulvovaginal atrophy or GSM, or libido, that may require specific attention. If they're happy, that all you really need to do is annual reviews thereafter for a risk assessment, whatever that means, and just to check in to see if they need it. Still, there is no longer a mandated end date for MHT. So there's not like, hey, 5 years, you've got your benefit, get off it. If you want to stay on it and the symptoms are still present, then you can stay on it. But what I do just for practicality is pick an age to trial off it. So if I started someone at 51, I'd say, hey, at 55, let's give it a run off it, see how you feel. If you still feel like rubbish, let's get back on it, and let's pick 60 as the next junction to try it again. And I find that at least because you're creating a stopgap so that it isn't just sort of habitual prescribing from there on in. And it's just not, people aren't stuck until they're 80 on this medication. Cool. Right. How to refer. So the really important stuff is that the heart of this program is Susan, who runs the hub for us, the cluster for the hub down in Western New South Wales. And I already sort of spoke about this, but as you know, our service is a tertiary referral centre that's 100% virtual. We have gynecologists proper doctors like endocrinologists, psychiatrists, psychologists, dietitian, and physiotherapist. And what happens is someone comes in, they get assessed, they'll be seen by Susan initially in the local area, and then fed up into our hub where we see them virtually, make a bit of a plan. And the whole purpose of this over about 3 months is to kind of tidy everything up and then filter them back into primary care for ongoing care. Because our job's not to sort of take everything over, it's really just to augment and supplement the community. There's also a choice to do what we call case conferencing. So if it's not something that you need to just send to us and you'd rather have a conversation with us and the patient, we can coordinate joint appointments for that as well. And Susan's wonderful at organising all of that, which is great. We're very, very lucky. Generally speaking, there is referral criteria. So it's for women with severe and complex symptoms, so premature insufficiency, people after chemotherapy. And the important part is also like, and this is the one that I think we understate, which is if you've started something and it's just not working, send it to us as the too hard basket. There's no shame in that. We've got plenty of different resources and MDTs and stuff to try and work it all out. So if initial treatment's not working, you're not sure what to do next, by all means, that would be someone who's suitable as well, even though they don't seem to be high risk in particular. And then, of course, anyone with a complex medical history is fine too. We spoke about that already. Cool. This is the referral form. We'll have some links to that shortly, and I believe it'll also be sent to you too. And I'm also happy to we spoke about the case conference model. I'm happy to help you as much or as little as you would like. I'm not some super duper genius expert. I'm just a guy. So I'm happy to help. I just do a lot of this. And so if you'd like to just have a conversation without the patient, I'm totally open to that. If you want to have a joint case conference, which we do occasionally, then by all means, if it's easier just to say, look, send to the hub, get a bit of a tidy up and get back, then that's great too. All right. But I'm here to help you guys in the way that you want to be helped, in the way that I can help, knowing that you're also experts in this area, doing the primary bulk of this work in the community. Cool. Oh, yeah, so let's talk about referral. So actually, I think that's the next slide. Perfect. Thank you for reminding me. So the referral form is live on Health Pathways through Western New South Wales. You can also, off the record, also just send a typical referral if you choose to. It's best to be sent through to this email address. And you can also, there's a phone number there for our lovely coordinator, and we've also got a direct email address for patient queries as well. So you get the form, fill it in, or another referral, it's up to you, and then you just email it directly to that, and we take it from there. The next thing you'll hear is basically correspondence from the appointment, and then eventually sort of a handover letter once we're done. That's all. It's pretty straightforward and easy. And that's pretty much it, I think.
But that's all. James and Susan, thank you so much for tonight. That was wonderful, and we'll certainly send out those resources to everyone that participated. But I appreciate your time very much. It was a wonderful to listen to that, James. Thank you.
Thank you for attending, everyone. And please thank Susan. She's the engine behind this whole thing. So yeah, we're very grateful and very lucky.
Yeah, the evaluation's in the chat, but thank you so much, everybody, for attending tonight.